we're a private company. We're headquartered in Australia. Much of our engineering team is based in North Macedonia, and the deployment of our product I'm going to tell you about was done in that country 11 years ago and has been going ever since. And you'll see some results from that when the slides are up. Basically, North Macedonia is about 2 million people, and it has a centralized national medical record and clinical platform for the public health system, which is the majority of the system in that country. This was an interesting project, and I kind of want to tell you the story, how we rolled out our product throughout the country, and how the system itself changed around this. A little bit of facts about Macedonia to put this in context. So there is a largely public centralized healthcare system. Macedonia is one of the post-Yugoslav states and an EU accession member. So it's kind of all public care. There are private hospitals, and they're responsible for a disproportionately large amount of healthcare spend, I think something like 30%, but very little actual health care because the public system is so cost effective, because it is cheap. So care is funded by the National Health Fund, and the vast majority of care remains public, except for GPs or family doctors who are in this kind of hybrid public-private model. So the health system has about 10,000 clinical personnel in it, and another 10,000 or so support and administrative staff. And they are spread across 3,000 healthcare institutions and 1,000 pharmacies. So these numbers down here about the amount of referrals that take place and admissions, all of these run through the single health backbone which underpins the system. So the vast majority of those 10,000 users in secondary and tertiary care, that doesn't count the GPs, which is another 10,000. The vast majority of those actually do their day-to-day work, or some or all of their day-to-day work, in our platform Pinga, which is this workflow and EMR system that sits across the country. You'll see a picture of it, I think, a bit later in the slides. So this is kind of it was a huge reform when this was put in, because it basically changed what software was used by every single worker in the public health system. Previously, there were dozens of solutions, and some of the public hospitals still have an HIS, but the majority of their users spend part or all of their day in our solution. And the HIS platforms that remain in use are all integrated, partly by regulatory change and partly because the users themselves clamored for this integration to take place. So the journey actually started with booking. Moj termin means my booking or my appointment. The initial mandate when the system was put in, and this is quite interesting because, a lot of public health mandates can sometimes be driven by a desire to put in a certain tool or process. This was a very solution-based mandate. The health minister in 2011 and 12 basically said, I want to get rid of inefficiency. We've got sites that are overloaded. We've got sites that are empty. We need some way to connect this up. So we are going to allow people to directly book their care, clinicians to directly book the care for patients. And beginning from this and an attempt to solve this one kind of thing, it was necessary to drill through and ultimately touch the very foundations of the health system, because just to book something in, you need to know what it's for, you need to know who it's for, and if you want to know what it's for, you need to know what it's about. And if you have this information of each appointment, you actually have the medical record, because reports and clinical outcomes, clinical outputs are attached to specific appointments and occasions of service. So how the kind of story went, this original mandate was put into a context in consultation with various entities in the healthcare system. And they basically said, all right, in Macedonia, once the system is in place, everybody must integrate. All referrals must meet a certain healthcare standard. And the initial and only standard was ICD-10 coding. They didn't want to go too big because it would be complex and the system was not ready for it. So ICD-10 was mandated. All prescriptions, the prescriptions came later, all referrals and then all prescriptions must be attached to a diagnosis. One consultation can have multiple diagnoses, but you can only attach a referral to one of those. So that's it. That's the whole clinical data standard that they started with, nothing else. And then on the back of this, and this was actually a huge reform, when making a referral, a clinician or a member of their staff needs to complete the referral, and the completion process involves making a booking. So they actually directly book you. You're not getting a referral for care. You're being told, okay, you've got a referral, and that's the time that you can go. And the time is not chosen for the patient. The patient is there with the doctor telling them when are you free. So they will literally turn their screen and say, all right, what time are you free? That's this map here. So strictly speaking, they have a time slot lookup view that is a bit more basic than this. But this is a public website that the government provides to basically tell people, whenever you think that the healthcare system is bad and waiting times are long, it's not true. Go here and you will see what the wait time is. These green pills here, my apologies, this remained in the Macedonian language. I should have transliterated it. This says tomorrow. This one is today. And this one is the day after tomorrow for cardiology. So there is a fascinating outcome here that I'll show you in a minute, what happened when this was opened up. But these kind of the points on the slide here. So the reform started with this clinical standard and the concept of creating a shared calendar across the healthcare system. So all clinical resources, these are clinicians, devices, and certain like walk-in clinics. So sometimes a clinic is, they will have 5 doctors assigned, and you're not booking with any one of them individually, but just the clinic. That has room for 5 people at a time, 15-minute appointments times 6 hours or whatever, on a given day, and people just fill that in. So this calendar was opened up for all bookings by authenticated clinical users, clinicians and their staff. So the main flow is so seamless, and as a result, system efficiency increased dramatically, which is what I will show you here. So I kind of went back into time for this graph because the results are basically consistent from here through to today. When the system was first put in 2012, waiting time, there were waiting lists all over Macedonia, like most public health systems, there's waiting lists. Waiting time was measured in weeks and months. These blue spots are the number of appointments delivered in a given week. This is like the daily average for a given week. And we did it that way because otherwise it would be too many dots and it's a bit chaotic. The orange line is the average waiting time for healthcare across the system. Keep in mind, this is December 2013, so the system had been in place for a year. Waiting time dropped from weeks to days, and by the end of 2017, it is an average of 1 day or same-day wait for any care in Macedonia. There are no more waiting lists for outpatient care. Obviously, surgeries too, you have to wait. And that doesn't mean people don't wait. In practice, the reason there is no waiting time is because if you're looking for a certain service and you live here, it will not be available necessarily that week in your town. But it's 30 minutes to here where there is a doctor available. So for urgent care, people can access care very quickly because there is a visible map of where all of these resources are available to your doctor. If it's less urgent, if they really want you to see a particular specialist because they're the best at something, the calendar is still open and they can see when these people are available. But the shocking result for me, and I did not expect this when we did this analysis, the average appointments per day went up about 50% by the time the system was in full operation. And this is just because when you have everything available on a map, you can point people somewhere where they can be seen quicker. It reduces waste. When people bank up and there is a waiting list, you also have people who are not doing their care, who are saying, I'll just wait or I'll go private. So this efficiency gain was produced with no additional investment in resources in the system, literally just better integration and coordination of care at a calendar level. I like to joke, with the plumbing, right? With the pipes in the background, you don't even see it, it's inside the wall, but you need to get these basics right to enable care to flow through the system, and when you do, it is a shockingly positive outcome. So the system was built up over time. We did not start with all of these features and modules. Actually, the initial plan of bookings, and then once that referral clinical standard came in, that became a de facto medical record, and then the government sponsored through additional tenders and investments, additional modules being put in. So there's a dental record, a full risk and list for ministry sites and hospitals, or all the public sites. The specialists now have more specialized pieces of the interface that deal with their clinical pathways. Probably the most comprehensive is actually, there's a dedicated diabetes and endocrinology module. There's a book about this, published by Springer, I think, with one of the doctors who, Dr. Ivica Smokovsky, who consulted on the development of this module. In Macedonia, diabetes management is handled by essentially like specialists. Other countries are different. You know, in Australia, where we mostly operate, it's actually managed by GPs and family doctors. So endocrinology is a very rare specialty for, you know, extremely complex cases. Sorry, I'll get to the next part in a minute. So, with the implementation of all of this built up over the last 10 years, finally this year, after years of badgering them, the ministry said, we're going to give people the access to their own record. So we deployed this year, in May, I think it was, or June, the Moe Zdravje application, which looks like this. So this is a patient app, mobile app. There's also a web portal, which gives people access to their record from the system. So all of these elements are in there, and this is now providing like a kind of like a community service. So not just a patient access, but it enables them to have a portable view of their record as they move through the system for any clinicians that aren't integrated. Most clinicians are, but some GPs still are not. And if they go private, you know, it's actually, we probably have 80% coverage now, but initially it was intended that they would be able to take this anywhere as well. The key aspects of this, and this is still very early days for the application. It relies on a national digital identity that was set up for Macedonian citizens, but not many people have this identity yet because this is a new thing. So the app is not super penetrated. I think we have only 20 or 30,000 users. But in principle, everybody has access to this. The ministry will be promoting it through the next year. So I'm also hoping to come back next year and then talk about how many additional people have put this thing on. But, you know, it works. The key here that was very a big part of the mandate for the development of the application was to have minimal patient effort. So people don't need to put data in themselves or connect to anything. The system already catches this information, and it's simply presented as is. Later, it will be implemented to enable people to put their own information in. It is my dream that they will move to goal-driven care, as you guys were talking about. You know, this is a future goal of the system, but it is not ready for that at an administrative or regulatory perspective. So I'll just kind of touch on these things. Once the platform was put in place, it was possible during COVID to very quickly roll out certain services. I think Macedonia was one of the first countries with a digital vaccination certificate, because the digital immunization and vaccination register was already there. It was universal throughout the system in one database, and it was we were able to quickly build that up. Telemedicine was another one. So we had specialists already using this, you know, software in their day-to-day operation. We simply embedded a video call function into the system so that any appointment with the flip of a switch would become a telecare appointment with a cloud, like a cloud video call platform. So I kind of blitzed through that. I can answer questions about it later if you like, but I really want to stress kind of the lessons we learned here. We didn't set out to even to build a national EHR initially. The ministry had a mandate of, let's get bookings done, and it became an EHR very quickly over the first couple of years, and then continued to be built up. So the thing I really want to share here from a kind of lesson learned about affecting systemic change and digitizing healthcare, it was extremely successful to keep the reform, I call it shallow, just ICD-10, nothing else, no big clinical standards, no SNOMED. Trying to change every doctor's way of working is already a huge endeavor. So keeping it as simple as possible is a good idea. And even that was a process. When the system was launched, there was a sudden and mysterious outbreak of cholera, which was nonsense, because A00.0 is cholera in the ICD-10 coding. And some clinicians were just like, nah, what the hell is this new form? You know, click, click, next, next, next. The minister slapped a bunch of wrists, and suddenly the cholera vanished. So I think it's still there in the system but that's an error, you know, garbage in, garbage out. With proper education, and once doctors could see the value, the minute doctors are getting referrals in with an ICD-10 code, and they don't need to understand the notes that came from some GP, or they puts them in context and helps them do their work, they start to see the value, and it became much more accepted once that understanding was there. So that's the shallow. And the other thing, I kind of went in reverse order there, is wide. The bookings only works because it's systemic. It probably would have worked in a smaller region, you know, covering maybe 200,000 or 300,000 people, but the outcome, that 50% jump in efficiency of delivery of secondary care, that came because the whole country is accessible. And it's not a huge country, right? It's like 3-4 hours at longest, or 1 hour, depending on which diagonal you take and how many mountains are in the way. But within a region, once you hit a critical mass of clinicians and a size of healthcare system, making sure that it is complete, the reform is complete across the region is, I think, a necessary precondition to get that kind of outcome. You know, letting people book in just one place, once the bookings are full, nothing happens. Once you have a system, it acquires so much more power because you are sharing and spreading load around the system. And then, once you've done it systemically and shallow, you can build. That diabetes module was put in later, and it was rolled out extremely quickly. Telemedicine was rolled out in the space of a couple of months across the whole country, every specialist, because they're already using the system day to day. It's just a software update. It does help that it is a cloud system. Nobody had to update any software. I should have mentioned that earlier. It is a cloud platform. It's built with modern technologies. So, you know, there's a lot of talk about centralization and decentralization of healthcare, about the way ecosystems connect. From our perspective and from the use case and the outcome we saw here, there is a huge benefit to centralization at a certain level. So, you know, I think the most important outcomes, one was the scheduling in the calendar, which, if you take nothing else away from what I've said, you know, that for me is the most important thing that can be delivered in a health system, because everything else, all of the fancy stuff, the clinical standards, the AI, you know, at the end of the day, a patient has to go somewhere and something has to be done to them there. A consult, a scan, a procedure, diagnostics, eventually, you know, an intervention. Just getting people to the right place to do the right thing is a very simple thing in principle, but very complex when you try and deliver it at an integrated level across a whole system. But just to kind of wrap up the points here, having enough centralized so that a change, when it is applied, can be done systemically means that you can slowly layer on improved processes, and the speed of rollout and the speed of deployment is vastly, you know, it's not just faster, it's simplified because clinicians speak a common language. You know, when in some systems, in every system that I'm aware of anyway, there are dozens and dozens of software applications. It's the same in Macedonia, but enough of the backbone and the day-to-day is in place that when something happens like the pandemic and a new process needs to be put in place, you can roll it out almost instantaneously across the whole system. Everybody can adapt to one new field on a form or one new button. Updating 36 pieces of software because there's a new clinical process, you create such a barrier to you know, driving the system. So that's something that I, you know, really wanted to reinforce and share with you as our experience from a place that you know, not many people are familiar with and doesn't usually get mentioned. But we had a remarkable outcome, and I hope it can be done in other places too. So thank you very much for listening.